which just played songs. It didn't do anything else. It was very basic. And for the Star Wars folks, that is when Episode 2 came out. So a lot of variety on there. But so takes the stage back a little ways for you, let you think about different things. Oh, thank you. Sorry, I forgot to record it. I didn't say anything exciting. Never mind, somebody started it for us. Cool. All right, so things have changed a little bit in the time since then, and we'll talk about some of those things in detail. So one of the biggest areas that we've seen change has been colorectal or kind of abdominal surgeries. So GYN cases, bowel cases, that sort of thing. So just kind of make you think about things. You've got a 70-year-old with colon cancer that's coming in to have a colectomy or a bowel resection done. Went somewhere, they did his history and physical, and wrote to make sure he was NPO after midnight. And this used to be, and it kind of still will be in some places, a blanket statement. So when you guys get out to clinical practice, you're probably going to see that your hospital is somewhere on the continuum from 20 years ago till now. It's not necessarily wrong. Some people just don't catch up or make decisions quite as fast as other people do. So, you know, everybody would be NPO after midnight, whether midnight was 8 hours from their surgical time or 12 hours. So we would have patients by the end of the next day that still hadn't made it to the operating room. Blood sugar was down, they were dehydrated, they were cranky because they haven't eaten. And then the other thing was a lot of these patients would have bowel preps done. So they may have had a pretty substantial fluid deficit already because they were NPO, and then we just made it worse. But we'll talk about that in a little bit. So this is the actual current recommendation for NPO guidelines. As I said, very few places follow this. A lot of people default back to the 8 hours, whether it's appropriate or not. So clear liquids, 2 hours, breast milk or kind of fattier milk, 4 hours, formula, 6 hours, non-human milk, so think like soy or something like that, is also 6 hours, light meals, 8 hours. And really the only thing that needs to be that full 8 hours is like a real meal. The other thing for you to take into account for some of these is the patient's medical history. Say you have a diabetic that maybe doesn't empty out their gastric system quite as fast as somebody else. You may want to add a little bit of time on that. But the area we get into trouble with the most is like clear liquids. You know, somebody had a cup of coffee on the way to surgery, and now we tell them they have to wait 6-8 hours. Sure that H&P is done. Again, verify the patient was NPO, and you'll see that a lot of times we really have to kind of drill down into, you know, the patient being NPO and what that meant, because people lie. I know it's kind of crazy, but they will lie to you. You know, to the point of rolling into the operating room and you go to intubate and there's gum in their mouth, or they've got a dip in, or like the last bit of food is in there. We would talk to them about general anesthesia, what to expect in the operating room, things for post-op recovery. And then we started doing some pre-medication stuff. So they would usually get like Versed or maybe Versed and fentanyl. And we were actually doing some PO stuff. Originally, it was COX inhibitors, primarily Vioxx, until that was kind of recalled, and then Celebrex. And really, that was the first step towards doing something ahead of time that would help out with post-operative pain. So that was kind of a big change for us. And we've come quite a ways since then. And we've also figured out that probably wasn't quite as adequate as it should have been. So a couple things for you to think about. The COX inhibitors really helped out on a couple of different pathways. And when we do the pain lecture next week, we'll go into a little bit more depth about stuff. And then when we start talking about some of the guidelines later, we'll kind of hit up some of the more medications. But, you know, the COX inhibitors helped out not only peripherally, but also centrally. So we got the patient to the operating room. We would go through and we used the 4-2-1 rule of fluid resuscitation. You guys will probably remember that from your pediatrics lecture. But it didn't necessarily fit anyone, really. It didn't fit the kids. It didn't fit the adults. And it missed a lot of things that we weren't taking into account. So we knew the patient had been NPO, so we started counting with their NPO time. So they were already deficit. We didn't have a good way of accounting for the bowel prep, which could be pretty significant. When they got to the operating room, we tried to account for evaporative losses, but that could be difficult. Blood loss could kind of figure into things and be difficult. And then the other thing you had to take into account is a lot of our calculations, like as far as allowable blood loss, were based off of laboratory values that may or may not have been accurate. So think about somebody that's like a smoker. Maybe they're hemoconcentrated, so they had their CBC drawn ahead of time, and their hemoglobin was like 16 and 48. It's not accurate because they live in a chronic state of dehydration. So somebody in that state, you give them a little bit of fluid, it dilutes them quite a bit more than somebody that's in a kind of normal happy hemostasis. PONV prophylaxis, we didn't do it consistently. And you'll figure out in anesthesia, there's really two big dissatisfiers for patients. They don't want to throw up and they don't want to hurt. So we weren't really doing much to stop them from throwing up. If they were already nauseated, we would give them something, but we weren't really doing a prophylaxis for these patients. And then pain management, and just to refresh your memory, 20 years ago was before we had this whole pain is the fifth vital sign thing that came out. So I think we were kind of more realistic as far as our goals for patients, but we did a very poor job of addressing them. We made patients understand that, you just had major surgery, things are going to hurt, but we really didn't do a good job of getting them comfortable. And when we did, our pain management was entirely based on opioids. We didn't look at any sort of multimodal stuff. We weren't doing a whole lot of regional anesthesia at that point. So we probably did our patients a disservice. So I'm just going to take you through kind of predicting fluid loss and where the patient stands. So if you have somebody with that 4-2-1 rule for the 70-kilo patient, they should be getting about 110 mLs an hour. With the NPO deficit, they're looking at 8 hours if it worked out to be 8 hours. They may be going 16 hours later, not 8 hours. So they need to get about a liter there. For the bowel prep, another 2 or 3 liters. So starting out before they get to the operating room, they're already down 3 to 4 liters of fluid. That's pretty significant for people. Most of us would not do real well if we were already down 3 or 4 liters of fluid and had it coming out of both ends. Then we take them to the operating room. We expose them. They start to have evaporative losses. So we increase the amount of fluid we need to be giving them now. And then, God forbid, they start bleeding, because then we're trying to give them more crystalloid to make up for it. You guys know that I'm a big fan of not treating blood loss with salt water, but some patients don't lose a whole lot of blood. They're already just in the state. So they come in, they're profoundly hypotensive already or volume depleted, and then we give them medications that are just going to make it worse. So you'll see these patients on induction generally do pretty poorly. It takes us a while after going to sleep to catch up with their blood pressure. So that was kind of one of the reasons I had you do that case study before with the Anasoft. So you started thinking about giving patients some fluid beforehand. And same thing with the one right now. You may see that septic patients need a little bit of volume to start off with as well, because they may be vasodilated. So things to make you think about resuscitating patients beforehand. And a lot of times what I'll do if I have somebody in this situation, if we haven't gone through a true ERIS protocol, is I'll go out to the holding area and start giving them some fluid then. So when they come back to the operating room, they don't crump on me. So as I said, at the time we did a lot of opioids because it was nice for us. They were cardiac stable, but they were kind of our driving treatment of any sort of pain that came up. You may see some local infiltration by the surgeon, but certainly not on the scale that we do it now. And it probably wasn't real effective either. It was more like checking a box rather than actually trying to accomplish something. And then we would do some epidurals. Probably not for this case. You would primarily see epidurals done for like Whipples or nephrectomies, some of the bigger cases. But for something, even though a colectomy is painful, we didn't put a whole lot of them in. And it was interesting. We really didn't have good outcome data for doing this. It just seemed like a good idea at the time. So that was kind of how we progressed. And what we found was we had a hard time getting them in, which was interesting either because people weren't doing much OB and didn't have skills. And then there was a pretty high failure rate. So patients actually weren't getting a whole lot of relief from this uncomfortable procedure they'd gone through. So we primarily did lumbar epidurals for these patients. One thing I think we will see in the future is the return of thoracic epidurals for these patients. Not necessarily for this, but for some of these cases. Or we're actually doing a lot of regional stuff right now with like erector spinae blocks, and patients are getting a lot of pain relief from that. The problem with these patients and putting in epidurals was what happened afterwards. So they may do really well in the operating room, but then they go to the floor, they go to recovery, and whoever's taking care of them isn't real comfortable managing that patient. We would have people fall. They would wear you out all night because the pump was beeping. They couldn't figure out if the patient could go to MRI, not go to MRI. Catheters were getting pulled out. You'd have patients with unilateral blocks, and now they're only getting pain on one side. So they turned into, even though it was a good idea at first, probably not the best thing ever. So we backed off of that a little bit and kind of went back to other things. So adding on to that, we started moving on to basic things like Ketorolac or Toradol. And what we figured out was, giving a pain medication, even though it wasn't an opioid, reduced the opioid requirements, which was good. The downside of that was that you were starting to see an increased risk of bleeding. And part of that is due to dosing, and part of it was due to the schedule at which it was being dosed. The studies that really looked at bleeding in Toradol were not one-time doses. These were patients getting usually 30 to 60 milligrams of Toradol every 8 hours for 4 to 5 days. And obviously that affects your platelet function. What we figured out since then is like 1-time and 2-time doses really don't have the same problem as those longer doses. And the other thing is that we've reduced the overall dosing, and we've kind of figured out there's a ceiling for most patients that's significantly less than the 30 to 60 milligrams we were giving them. So most patients now are getting 10, 15, maybe 30 milligrams, which seems to have helped out there. There's also a risk of either inducing or worsening a kidney injury if you've got a patient that's renal function is not real great to start off with. So that may be a consideration. We started using some dexmedetomidine or Precedex, but consistent dosing wasn't there. I remember when it first came out, we tried using Precedex for everything. Like we were in GI lab and we were trying to get people to do scopes with Precedex. It was a horrible idea, but you learn from it. And then new again, we had used ketamine for anesthesia for a long time, but it kind of slowly started to make a return with a little bit better dosing scale than what we'd had before. Before we were giving, especially for pain management, like full dosages. So patients may get like 2-3 milligrams per kilogram, and they would wind up with some of the psychological complications of that. And we figured out the effective dosing was actually significantly less than that. So like 0.25, 0.3 milligrams per kilogram is enough for pain. Other things you would see done that have kind of come and gone, we were putting NG tubes in anybody that had general anesthesia, which now we know is inappropriate and probably creates complications. I know of several cases, one of them involving a resident in Florida where they put an NG tube in and caused esophageal rupture, which actually went unrecognized and created a whole another series of problems. But a lot of times now we don't do gastric decompression if we don't need to. So for bowel cases, we probably would because they're going to need that for the field. But for like a traditional lap chole, probably not. On the other hand, if you have any sort of emergent case, you probably want to go ahead and still put an NG tube in to make sure you've reduced your aspiration risk or PONV risk. We've talked about antibiotics and keeping the patient warm. But really, this is when we started talking about moving into PONV prophylaxis. So patients that are a little bit higher risk, females, non-smokers, younger patients, longer duration of anesthesia can affect things. Shorter duration of anesthesia can also affect things. Opioids can induce nausea and vomiting, or somebody that has a pre-existing history. So these are patients we slowly started to figure out we really needed to do something about. And then we started looking at kind of complaints from patients. As I said, one of the biggest ones they complain about is vomiting or nausea. Pain is up there. And then another one that's kind of strange is gagging on the endotracheal tube. So when we think about patients waking up, we talk about awareness and we worry about awareness during the surgery. They're talking about awareness, remembering anything. So it might be something as simple as, they woke up with the endotracheal tube in their mouth. Well, that was okay. Maybe we wanted you awake because you were difficult airway or because you were a higher aspiration risk. But a lot of times that's not explained to patient. And then as you kind of follow the list down there, you see that there's less and less importance assigned to things. So what did we start doing as far as nausea and vomiting? And again, this is from early 2000s. So we started thinking that patients were a little bit higher risk of nausea and vomiting. Maybe we shouldn't do general anesthesia. So you may have a patient that purely got a regional block because they were high risk for nausea and vomiting, but we abandoned all the low risk patients. They weren't getting anything at all. And we used the APFL scale to start figuring out where patients would fall in there. So 2 is kind of the dividing line between whether you're low risk or high risk. So somebody with 0 or 1 risk factor is pretty low risk. 2 is moderate risk, and then 3 and 4 is high risk. A lot of times on your preoperative assessment, you'll actually go through and calculate the APFL score. And this was what you're looking at there, is just their PONV risk. So if you've got a female patient, they've obviously already got 1 point. Being a non-smoker adds a second, third for a history of PONV. And then 4th, if you intend to give postoperative opioids to this patient. So if you had a female patient that was a smoker, no history of PONV, and you were planning on doing just a regional blockade, they would still be pretty low risk. But you can see how things build up pretty quickly. A female that's getting postoperative opioids is already moderate risk. So the pretty decent chance that almost all your patients are going to be a 2 or higher. So patients that are moderate risk, you basically want to consider giving them 1 agent. Almost all of my patients get at least 2. They usually get Decadron as well as ondansetron. But anybody I have that's higher risk, or I kind of consider them like super high risk, patients that have a strong history of PONV, maybe the surgical case has a history of PONV, they always get multiple agents. So usually what I'll do for those patients is, I'll give them the Decadron. I may give them a second dose of Decadron and a second dose of Zofran. We get hung up on dosing for these, but if you look at like dosing scales for patients that are undergoing chemotherapy, they'll get crazy doses like, 20 to 40 milligrams of Decadron, 8 to 16 milligrams of Zofran. So don't worry too much about giving too many of these medications. The exception to that is, again, if you have somebody with like cardiovascular complications or long QT syndrome, something like that, you probably want to be cautious what you're giving them, and just keep an eye on things there. And there's other things you can do for those patients as well. Consider reducing your triggering agents, eliminate opioids. That will help the patient out. Think about non-opioid anesthesia for them. So what happens when they get to PACU? Again, we're going to continue to give them fluids at that 110 ml an hour rate. So if they weren't swollen already, they're pretty swollen now. We're going to try and keep them warm because we've obviously done a poor job of it, and they're going to tell us about it. And then we're going to give them more opioids. So like I said, a reasonable pain goal, we're not trying to get rid of things. And what we would do generally was bolus them with IV push medications until they were comfortable, and then start them on a PCA pump or a patient-controlled analgesia pump, which would continue to the floors. We still use some PCA pumps now, but they're definitely not as common as they used to be. Problems you ran into, they were expensive. They took time to program. They were kind of labor intensive for the nurses, whether they were replacing like the cartridge or the syringe in there, getting it programmed, finding the key to lock it or unlock it. So they still get used, but we've gone away from it, and they certainly don't have kind of the same importance they did then. So things have changed. I'm glad some of you still remember what a Palm Pilot was, but everybody's got an iPhone or a smartphone of some way, shape, or form now. We've got a new Star Wars movie out, and this is still several years old, but makes you think about how far we've come. So what is ERAS? And it's a multi-step process, but it's basically a systematic and validated management model based on the best available evidence. Now, with that in mind, evidence is constantly changing. part of what you guys do when you go through and do your scholarly activity will probably be based off of some sort of ERIS guideline or improving the evidence that's available, whether it's creating new evidence or going through and evaluating the evidence that's in practice now. And one of the big things is that, a lot of things in medicine we've done for a long time without any sort of real reason. We generally call those dogmas, but, like one of the big ones is the preoperative fasting. And we're going to talk a little bit about, other things we can do. Obviously, having your patient come into the operating room and already being down 3 to 4 liters is probably bad for them. But there's a lot of pathways and guidelines that we kind of follow. And our goal here is to enhance the patient's recovery after surgery, get them out of the hospital faster. But it's really a continuum from start to finish. So it starts with pre-op, and pre-op being basically as soon as the patient decides they're having surgery. And then it's going to end at that follow-up appointment. So we want to make sure the patient's coming back in and still doing well. So we kind of break it down into 3 different time frames. And as we finish up this lecture, we're going to go through and look at these time frames in great detail. But so pre-op is basically from the time the patient decides they're having surgery until the night before. Intra-op is starting the morning of surgery, continues through the procedure itself, and then finally into the recovery room. And then post-op is getting out of PACU, whether you're leaving the hospital or staying in the hospital for a little bit longer. And then post-operative all the way back to when you come for your follow-up appointment. So these are kind of some general guidelines for, I called it the must-haves, but things that you really need to have for these patients. And a big change for us has been patient education and counseling on the front end. So talking to patients beforehand to see what we can actually do to improve their condition. And a big part of that for us is going through and analyzing the patient's risk and truly maximizing them. You'll see sometimes surgeons do this, as I said before, like specialty surgeons. They may tell a patient they need to lose weight or be able to accomplish X, Y, and Z physical therapy or something else before they'll consider having the procedure done, which is a big change from before where we'd cut on anybody and then we wondered why we had bad outcomes. So the 2 big components as far as the preoperative are patient education and then assessing the risk. The other thing you'll see as far as kind of the patient education piece is realistic expectations for surgery. Talking about the alternatives that are available. Do you want to have an epidural? Do you want to have regional blockade? Is there something in your history that makes us think we should do one versus another? Moving on from that to the intraoperative period, we've gone away from that 8-hour NPO time. And what we're having a lot of patients do now is a carbohydrate-rich drink, usually 2 hours before surgery. So depending on your setup, they may drink Gatorade, for instance, on the way to the hospital, or they may actually drink it, if they're a later case, they may have one when they get there in the morning, and then one again a couple hours before the surgery takes place. A lot of times they're going to get preoperative medications. Again, if it's somebody that's like first case, they may get a prescription and take it that morning before they come in, or they may get it when they get to holding. But we're using a lot of like Tylenol and gabapentin, Celebrex. They may get steroids ahead of time. But we're trying to reduce the amount of opioids that are given. And we know that opioids adversely affect not only brain chemistry, but outcomes for patients. Think about that patient we were talking about earlier that had a colectomy. He does great intraoperatively. And the most painful thing for him is when his bowels start moving later and he winds up with an ileus or he's constipated from all the opioids we gave him to make him feel better. So we're kind of cutting our hand off to spite our face. And we want to continue this multimodal analgesic approach, not only just in the operating room, but also all the way through discharge and home. Now, depending on the patient's condition, you may reduce some of the medications or alter some of the medications that are given. But think about it. It's not just while they're in the operating room, period. And then finally, post-operatively, we need to get these patients up. If you worked in a busy cardiac ICU, it was pretty common for us to get patients up within 24 hours of surgery. The last couple of years I was there, we moved up to within 6 to 8 hours of surgery. Some patients now are getting fast-tracked. We're doing cabbages without any sort of opioids. We may extubate them in the operating room, and then they're up in the ICU within a couple hours of getting back to the unit. So nice thing for that is it helps reduce pain. And then we're also decreasing that risk of DVT, The patient feels like they have a little bit more control over things, and they're getting back to a little bit more of a normal physiologic function as opposed to laying in bed. And then finally, the follow-up part of that is formal discharge education that includes, what do you need to do to get around? Is this somebody that's safe moving? Is this somebody that needs to have help getting around? We don't want this patient going home and falling, especially if it's due to something we've done. If you look back at like epidurals and regional anesthesia, discuss with the patient that, hey, we provide you with a nerve block that's going to block your entire arm. You're not going to have movement or sensation for the next 3 or 4 or 24 hours. You need to keep your arm in a sling. You're not going to feel it if you bump into things. Talk about wound care. You don't want them getting infected. We talked about how it'll affect us if they bounce back as a healthcare system. And little basic things, keep it clean. Don't roll around in the dirt, silly stuff like that. Part of this lecture came from a presentation I did with a friend of mine in Michigan that works at a spinal surgery hospital. So if you see MSSIC, that's the Michigan Spine Surgery Institute. So this is part of what we talked about there. Things that you need to assess for this patient ahead of time. Look at their blood sugar. What is their A1C? Is this somebody that is smoking? Can we see about getting them to stop smoking beforehand? With that in mind, we know that we don't want them to quit like within a day of surgery. We really want this to be done a ways out. So that's why it's important to do this early on when they make the decision to have the surgery. Tobacco use also decreases your wound healing, so these patients don't do very well. From a nutritional screening standpoint, one of the big ones we look at for orthopedic stuff is their albumin level. From an anesthesia standpoint, that's important for us because we need albumin to transport our medications around. From their standpoint, if they have low albumin levels, it's one of the highest risks for poor wound healing. So the patient may need nutritional improvement. They may need some sort of supplementation with albumin in the operating room. We want to look at the medications they're taking and how they may affect medications we're going to give them. It's not uncommon for older patients to be going to multiple doctors that are giving them medications that counteract what somebody else is doing, or you may have additive effects as well. And sometimes it's when you have that first person that looks at the 5 different medication list and puts the pieces and parts together to figure out the patient's taking too many medications for something. Drug and alcohol use is always concerning. Is this somebody we need to get out of the hospital before they DT, or at least be well aware that that's a possibility? From an anesthesia standpoint, it may affect our plan. If they've got a longstanding history of narcotic abuse or use, it may be difficult to achieve pain control. The other thing you see, especially with patients with chronic pain issues, is they may not necessarily be pain. And that's one of the issues we had when the whole pain is the 5th vital sign came out. People were wanting pain medication, not because they were in pain, but because they wanted to get high. So finding the dividing line between treating their pain and them getting high was kind of hard to do. Obviously, patients that are anemic, we want to detect that earlier rather than later if we can. Look at their physical activity. I put prehab here, but a lot of these patients that are going to these special facilities are having pre-physical therapy. So they go and get physical therapy done ahead of time to strengthen those joints, strengthen those muscles before the procedure. And that way they have better outcomes on the back end. Again, if we have patients that are obese, they may be counseled to look at losing weight. Patients with sleep apnea or higher risk, we go through and try and assess those. It may be something as simple as asking someone to bring their CPAP with them to the surgery center because we don't want them to obstruct. Just flipping over to the chat real quick, Tyler asked, would someone high risk for PONV be a good candidate for an EKG pre-procedure despite age? And it really depends on why they're high risk. Being PONV alone would not really be a reason to get an EKG. If you're concerned about them having prolonged QT syndrome or some sort of conduction delay, you may consider it. But just PONV alone would probably not be a reason to get it. Look at other factors, age, polypharmacy, that sort of thing. And then again, what medications you intend to give them. Even though there are lots of medications out there that prolong QT intervals, droperidol is the biggest one. Zofran can also be problematic. Metoclopramide can be problematic. A lot of times we don't overlap those medications. So when you actually start looking at like causes of PONV, We usually try to pick like one medication from each category and then avoid triggering agents. So like a Zofran, a Decadron, a Benadryl, making sure they have adequate fluid, that sort of thing. So I probably wouldn't get an EKG just because it was somebody with PONV. All right, so that kind of covers the preoperative phase. So things to talk about as far as the formal patient education. You'll see that patients that really understand what's going on generally have better outcomes, and they're realistic about things. If you just had your sternum cut open, it's probably not going to feel real comfortable for you. Same thing if you just had your hip replaced. But if you have a little bit of discomfort, we want to get it to a point where it's manageable, not to the point where it's all the way gone. The other issue you run into is that there's a lot of variation when we go from one surgeon to another. Dr. X wants it done this way, Dr. Y wants it done that way. When you have so many different pathways, it creates the potential for errors and complications. So what we've done is kind of shifted things back to the patient-centered approach. So recognizing the issues the patient brings to the table and dealing with those. And then finally, the other part of this is that the patients that get there and they participate in this, they feel a little bit more empowered and they feel like they're actually accomplishing things. They have some control over their care. So, you know, if you think about it, it doesn't matter which patient or which surgeon is doing the case. You're having a surgical procedure done. We've looked at your risk factors. We've gotten you into a clinic somewhere. And then finally, the other thing is that we want to make sure we document this was done because that's going to turn into a financial incentive for us. It's not there yet, but this preoperative screening and evaluation and preoperative teaching is quickly going to become a sticking point. Really, the only thing you see right now as far as that goes is smoking cessation. So you have a patient that was a smoker. Did they smoke on the, or first of all, did you tell them not to smoke because smoking is bad for you? Did they smoke on the day of the procedure? And a lot of times you're going to have to document that. So risk assessments, there's a whole lot of different scales out there. We're going to look at that a little bit better. But some of the big ones we talk about right now are eating. So, you know, are you nutritionally impaired? Obviously, if you have somebody that's rolled in that's cachectic and they're not eating well, you want to try and refer them to a dietitian if possible. Diabetic patients can be a complicating factor. They may have never gone to a dietitian, or they don't remember, or they didn't follow the instructions they were given. So smoking's bad for you, as I said. It increases your risk of infection as well as your risk of cardiovascular complications. So if we're able to get them to stop smoking ahead of time, that's probably important. You know, a couple specific things with their diabetic patients. Are they high risk? So the high risk ones, think about a hemoglobin A1C greater than 7 or persistent blood sugars greater than 200. As I said, depending on where you look, you'll see that 180 to 200 is kind of the cutoff for where we want to keep their sugar. And then again, depending on what the patient's doing, is this somebody that's NPO? You know, if you've got diabetic patients, it's very important to make sure that we're not interacting with their medications by making them NPO. Sometimes they'll take like a long-acting insulin like Lantus the night before, but then they don't eat. And that can obviously be problematic. They show up in the morning and their blood sugar's in the toilet, or they don't show up because their blood sugar's in the toilet. So this is just kind of a basic risk assessment tool for you for patients that are a little bit higher risk and kind of where to refer those patients. So if you've got somebody that smokes, talk to them about not smoking. It says surgeon here, but what you're seeing more and more, as I said, is that's going to anesthesia. So we have a preoperative clinic at JPS that patients that go to that are any sort of increased risk. And the nice thing from our perspective is we get to talk to them early on. We get to start establishing plan. But probably more importantly is we recognize things that are going to get the case canceled. So it's really annoying to everybody if the patient shows up on the morning of the surgery and then their case gets canceled. So that way we can kind of find some of these areas that are problematic early on. So smoking is kind of an annoyance for most patients. It's not a have to fix. Diabetics, we want to try and get that under control or at least better regulated prior to surgery. If you have somebody that's anemic or high risk for anemia, this may be somebody you consider getting some oral supplementation ahead of time. From our standpoint, if they're profoundly anemic, we need to make sure we have blood available for them or at least a type and screen. Obese patients, consider getting them referral to bariatrics for counseling. They may pick up a nutrition consult there. And if you have a BMI over 40, a lot of times we recommend that you avoid elective surgery. With that being said, it doesn't always happen, and elective is kind of a relative term. Our elderly patients probably need a geriatrics consult ahead of time, and try and follow those patients a little bit longer. One of the big areas we run into for them is that they'll have post-operative cognitive effects or delirium. All right, so the intraoperative phase. Remember I told you intraoperative is basically that day of. So we're trying to limit their fasting, so we're not doing the 8-hour thing. We don't want them eating full meals, but we're going to go ahead and get that carbohydrate-rich beverage in 2 hours before surgery. A lot of times we're not putting Foley's in these patients unless it's a longer case or for some specific reason, like I said, decompression of the bladder for surgical access. We're trying to use more multimodal analgesia with limited opioids. And we start there and continue it on through discharge as well as all the way home. Trying to do things that limit blood loss. MIS is minimally invasive surgeries. So smaller incisions, using microscopes, medications that may decrease blood loss like TXA or tranexamic acid. Our goal for these patients is kind of keep everything normal, which is something easy to say, but it's a little harder to do. So goal-directed fluid management, try and maintain normal volemia for these patients. You may use advanced monitoring to try and keep that patient in that position. Normothermic, so we don't want them hot, we don't want them cold. Blood sugar within normal limits. Administration of medications to eliminate nausea. And if we do put a Foley in, we want to try and get it out as soon as possible. So as far as what happens to the body with surgical stress and being NPO, that surgical stress increases the risk of immunosuppression and insulin resistance, decreases the glucose uptake. So a lot of times we'll see that these patients, just through surgical stress, will have an increase in blood sugar. They'll also have an increase in gluconeogenesis. So as if there wasn't blood sugar going up high enough because they weren't using it so much, we're also producing more. We generally have a catecholamine surge, either through surgical stress, through anesthesia, or both. Again, remember the medications you administer and how it can affect things. You'll also see increased levels of cortisol, glucagon, GH, IL, IL-6. And then post-procedure, we tend to see that there's an increased lean tissue loss, which obviously impacts our strength, our mobilization, and our wound healing. So surgical stress and being NPO is obviously a bad thing. Unfortunately, we can't eliminate surgical stress, but we can do things to help manage and decrease it. We've got a group right now that's looking at changes in blood sugar in diabetic patients undergoing lap choles. And it was interesting what they found is there's still a pretty significant increase in blood sugar levels for non-diabetic patients or patients that don't get any sort of steroid undergoing surgery. So avoiding medications that increase their blood sugar because of purely not wanting to increase their blood sugar may be a derogatory outcome. So you may consider going ahead and giving this patient steroids anyways. So this is just talking a little bit about the carbohydrate loading. Decent amount of studies out there that looked at a whole lot of patients. And this was 10 years ago. But what they found was that the carbohydrate drinks significantly improved insulin resistance. They also improved kind of the patient comfort factors. So patients that are thirsty, they're hungry, they're anxious. It didn't really help out as far as the muscle mass because we talked about how important it was to preserve that muscle mass. So maybe one carbohydrate drink is not enough to prevent loss of muscle mass. From our standpoint, one of the big things we worried about when we started changing NPO times, in some places we'll take this up to as close as an hour before surgery, is there was no increased risk of aspiration, which is something we obviously worry about in this population. So kind of the conclusion then was that it was probably safe to go ahead with a lot of these different markers and go ahead and continue with the carbohydrate loading. All right, so this is from Penn State, and this is from their neurosurgery clinic. And they had kind of a multi-factor approach here. And again, you can see that it goes from the preoperative clinic all the way through the patient going home. And there are a variety of steps in this. So the first thing is providing the patient with education. Provide them with realistic expectations about things, talk about dosing. As far as medications, one of the big things was, again, moving to that multimodal stuff. So gabapentin, NSAIDs, Opioids may still be part of the pain regimen. We're not necessarily getting rid of opioids. We're just trying to reduce our reliance on them. Another one that's kind of come back into favor, and it seems very basic, is Tylenol. A lot of our patients will get PO Tylenol, and if that's not a possibility, we may give them IV Tylenol. It's recently become generic, so one of the limiting factors before was the cost. Now it's basically the same price as the PO version. The use of local anesthesia, whether it was through regional blockade, infiltration of the surgical site, adjunctive medications, so think about like Decadron, muscle relaxants. I give a lot of my patients, especially for major surgeries, Robaxin, which can also be given IV or PO. And then finally, as I said, we're not abandoning opioids altogether. You may have to consider like IV opioids for patients needing rescue stuff. And this is just kind of an example of some of the medications they use. So what they do morning of surgery is some Tylenol and gabapentin. Pre-incision, their patients are getting ketamine, they're getting lidocaine. The surgical site also gets infiltrated. They were doing a ketamine infusion as well as a lidocaine infusion. A lot of times for my patients, I'll give a bolus of ketamine at the onset of surgery. And then to reduce workload on me, instead of doing an infusion, I'll do periodic boluses throughout the case. And then moving towards closure, some ketorolac. If the patient had an epidural in place, they may give some neuraxial opioids, some fentanyl or morphine. Again, they may consider infiltrating if they hadn't done it previously. And then post-operatively, go ahead and start the patient on Toradol and Tylenol, and continuing that for a while there. You see they limit their Toradol to 3 days, but Tylenol you can continue for quite a while there. So post-operatively, as I said, one of our goals is early nutrition. So early ambulation, get those patients out of bed quickly, get them moving. Early nutrition, get them back to a baseline diet or what should be a more appropriate diet. Part of that is getting them out of bed to eat, getting them back to a little bit more function. We see those patients that kind of linger in the bed, and we know that's a bad thing for them. Again, following up with those patients as far as like incision care, recommendations for mobility. And then following up with these patients when they go home. One of the things I tell the residents when I work with is anytime we do something new or it's something new to that resident, you need to go talk to the patient and see if it worked out. Because it's really important for you to understand, was this helpful? Was it not helpful? Every patient's different, and they may be able to provide you with some sort of perspective that helps you improve your anesthetic for other things. And then finally, in this post-operative phase, you want to discontinue the opioid sparing technique that we used. That's not something you want to continue long-term in its full respect. You may continue some of the smaller aspects of it, but the patient should get back to a normal baseline pretty quickly. So a couple little things we're going to talk about, fluid management and kind of how we can do that. One of the big parts of that is goal-directed therapy. So we're using a lot of non-invasive or less invasive monitors. FlowTrack, Cheetah, Clearside are a couple of the specific brand names. Most of those are done through either connection with an arterial line or some sort of percutaneous tracing. So when we're using crystalloids for these patients, we want to try and avoid normal saline if possible, just because it generally creates an inflammation on its own. And then the other part of it is that a lot of these patients benefit from increased use of colloids. We talked about how important albumin was for these patients for their wound healing. You may see that albumin is used more, not only just because of the wound healing ability of it, but also because it stays intravascular for a longer period of time. So opposed to the crystalloid that creates edema, if you can give albumin or something else and it stays intravascular, it's a little bit better for the patient's fluid status. And this is just different examples of stuff. One of the things that I talked about was, apps that are available for you. Edwards has a great app available that you can go and download for free that helps out with a lot of their different products. It's Edwards Clinical Education, and it'll take you through things, everything from like fluid management to using their devices. If you can't remember how to hook stuff up, it'll help you do that as well. That's the one I'm most familiar with, but some of the other non-invasive ones, like Cheetah uses a series of percutaneous sensors that may be helpful for you as well. So one of the other questions that comes up, do we still need a bowel prep? And what we found is if you didn't have a bowel prep, you had an earlier return of bowel function and a shorter hospital stay. Patients that didn't have a bowel prep had no difference as far as leaks from the anastomosis or wound infections. The other big part of that is that you're taking 2 to 3 liters away from that fluid deficit, so that patient's a little bit closer to maintaining that normal that we talked about. A little bit more revision on that carbohydrate loading. So up to 2 hours before surgery, there's no increased risk of pulmonary aspiration, reduced risk of thirst, hunger, and anxiety, decreased insulin resistance, questionable effect on the muscle strength and muscle mass, but we do know that you have a shorter hospital stay and accelerated recovery. So let's talk a little bit about pain management for these patients. And what we found is that if you're able to basically get to a steady state and maintain it, the patients do a little bit better than using PRN opioids. And one of the reasons that's really important for us is those PO medications play a stronger role because they get to steady state and they stay there. The other part is, as far as our education piece, patients getting medications into their system before they need them. So if somebody really waits till they're hurting and then they try to take something like Tylenol is probably not going to work really well. Then they're going to have to turn to something like an opioid to try and compensate for it. So what we found is if you have something like a neuraxial opioid, think about an epidural catheter, a PCA with a basal rate, or a regional technique, that you're able to maintain that steady state and you don't have the big swings that you see. So that's something for you to think about with your patients. And this just kind of shows you, as far as how the patients go, that they do a little bit better with other things outside of opioids in terms of nausea and vomiting. So we're starting to see other medications used. One thing, for instance, is we're putting in a lot of pain catheters, and it's basically you're doing the same nerve block, but instead of doing a single injection, you'll leave a catheter in there. So those patients will continue to get medication over a long period of time. We actually send our patients home with it. They've got a FedEx box. They drop it in the mail and send it back to us, which doesn't seem like it would work in a county population, but it actually does pretty well. But the nice thing is, by decreasing that opioid requirement, your rate of nausea and vomiting goes down pretty significantly. This is, again, kind of what we talked about here. So other things for you to think about as far as like intraoperative stuff, these are a bunch of different medications. So at the site, you can consider infiltration with local analgesia. Tylenol helps out, as well as some of the anti-inflammatory agents. As you start becoming more core, you can administer local anesthetic by those peripheral catheters like I talked about. You can also consider the effects of alpha agonists like dexmedetomidine. Our volatile agents help out a little bit with pain as well. This just kind of takes us through specific things and kind of how they affect pain management for our patients. So COX inhibitors, again, reduce our opioid requirements by about 20 to 30%, as does Tylenol. Ketamine has a nice opioid sparing effect. And the big thing there is, just by the way it works, it can also help out a lot of the times with opioid resistant pain. So you're seeing more places that are going to the use of ketamine as a first line pain medication, again, in a low dose, like 20 or 30 milligrams. Alpha agonists like dexmedetomidine not only reduce our opioid requirements, but they also reduce your anesthesia requirements. So a patient may have a decreased MAC by getting dexmedetomidine. So, and the other thing is, we're starting to use these medications in a variety of ways. When I talk about dexmedetomidine, you think about it primarily IV. We're putting this into some of our neuraxial blockade, and we're also putting it into some of our peripheral nerve blocks, and it seems to help out pretty significantly. Clonidine is an older medication, and by virtue of being older, it's a little bit cheaper. Primarily, the way we use clonidine is either in a PO formulation or as a patch. Both of those are okay, but if you're someplace where you don't have dexmedetomidine available to you, especially because of cost, you can consider using clonidine. Epidural anesthesia is pretty beneficial. One of the big things it helps to do is reduce that surgical stress response, but we do have a pretty high failure rate of it. 30% is pretty significant in my opinion. Gabapentin, corticosteroids continue to reduce your opioid requirements. And then when you look at peripheral nerve block versus opioids alone, you provide superior analgesia, reduce your risk of PONV, reduce duration of stay. But again, you have a complication right there. Nerve blocks don't always work. I had a patient a couple weeks ago. One of the anesthesiologists had gone in and done a block. Patient got to recovery. It was an excruciating pain. One of the nice things with our system is we can go in and actually look at the procedure it was done. Did they have good visualization of the anatomy? Everything looked great. I went through and offered a rescue block for the patient. He was agreeable. I did the same thing she had done and had better results. So sometimes we can't explain why things work or don't work, but there's always a risk that it won't work. So we're going to talk a little bit about kind of the newer things that are on scene. We've been doing peripheral nerve blocks for a long time. So think about like your extremity blocks, but kind of thoraco-abdominal stuff is a little bit newer to the scene. So one of the first things that came into play was the use of our epidurals, and we've kind of talked about that a little bit more. But more recently is for thoracic stuff, the use of the erector spinae block or transverse abdominis block. And these are both pretty easy to perform. Erector spinae is a little bit easier because you have a kind of a solid reference point. So if you look at that lower right screen, that's going to be the transverse process and the spinous process there. And you're actually able to go down and you're essentially going to be right up against it. And you're going to spread that local anesthesia there. And it's kind of nice because you get relief for like 3 to 6 levels with just one injection. This is one of the big ones. We're putting catheters in patients now. So, somebody that had a thoracotomy in years past, we would have considered an epidural. They probably still would have had a lot of pain. That erector spinae block is pretty beneficial for the patient. Moving down into the abdomen, there's 2 kind of predominant blocks, transversus abdominis plane or a TAP block, and quadratus lumborum or QL block. The advantage of a QL block over a TAP block is you generally get a little bit more kind of sensory and somatic block as opposed to TAP, you just get a little bit of sensory block. The downside is QL is a little bit harder to perform and it's harder to identify the landmarks for the patient. And this just gives you an example of where the local anesthesia actually goes in between the muscle layers. And so these are kind of fluid or field blocks. You're not able to actually see the nerve there. I'm going to flip back and forth a couple of times. So what you're doing is identifying fascial planes where the nerve should be running. So that's part of the risk you run is you may not get a good block because maybe the nerve's not where it's supposed to be. But we generally use a little bit higher volumes there, which help out so the patient gets a little bit more relief from that. So these blocks are generally performed on patients that are asleep because they're a little bit uncomfortable. You're going through multiple muscle layers. And you can perform them in different techniques depending on exactly what area you're trying to cover. So again, just kind of revisiting those last couple components of stuff from the preoperative standpoint, you've got to make sure you get preoperative counseling in, discharge planning in, not a bowel prep if you don't have to, some sort of VTE, pre-warming the patient, and getting antibiotic prophylaxis on board. And one of the issues we run into is when we start expanding stuff out, it stops being just us. You'll see that we have to involve multiple people. Maybe you have to have a preoperative clinic now. Maybe you have to get that day surgery nurse to give medications for you. When we first started doing URUS stuff at my old hospital, I had to actually walk to day surgery when the patient first got there, pull the medication out of the Pyxis and give it to them because the day surgery nurses couldn't quite figure that out. You would write the orders and they would never get done. Fortunately, over time, that's changed. But when you go someplace, especially if you're in the midst of like a cultural change, you may see that you have to be the driver of the initiative and the advocate for your patient to make sure this happens. So we're pretty clear that clear fluids should be allowed in two hours before induction of anesthesia. You can probably continue solids up to about 6 hours. And the reason I put this there is to remind you of how important that is because you're probably going to see that fasting period scale again and again, including on boards. But the other thing is maybe the patient doesn't get that carbohydrate-rich beverage. Should we let them have some water, if they're a couple hours before surgery? Are we giving them pills with water? It's probably okay for them to have some water to try and swallow this down, not sucking it down with nothing available. This just takes you through kind of the multimodal approach to POMV prophylaxis. We talked about risk factors, patients that are a little bit higher risk for things. Children have a little bit different risk. One of the biggest things we see is like ocular surgery can be problematic for them. As they get a little bit older, they're increased risk of PONV, longer procedures, or again, having a relative with a history of PONV. So things you can do to reduce the risk. Nitrous oxide is like one of those things that people can't really seem to make up their minds about. There's some literature out there that says it's a triggering agent. There's some other literature out there that says it's perfectly fine. If I have somebody that's high risk for PONV, I avoid nitrous. But with that being said, I also avoid volatile anesthetics. So if I truly have somebody that's high risk for PONV, I'll do Ativa. If I use an opioid at all, I'll use something very short acting like remifentanil. I generally run them on a propofol infusion, which in itself is an antiemetic. And then I try and avoid opioids if possible. And there's a whole lot of different things down here that make you think about different approaches to the treatment of and prophylaxis for PONV. We've covered a lot of those. If anybody has any questions, feel free to let me know. So this is kind of some things that we're pretty clear about. Active warming is good. Multimodal pain management is good. Not putting in G tubes in everybody is good. Multimodal PONV prophylaxis is good. But things we're not so sure about. Goal-directed therapy. Am I going to damage my patients by underperfusing? So unfortunately, we have this habit of overshooting things. If you don't have the availability to do true goal-directed monitoring, you may consider kind of giving them a little bit more cushion for administering fluid. So don't under-resuscitate those patients. Other things for you to think about, long-acting opioids. We don't want patients to be in pain, but a lot of times as practitioners, we turn to opioids as our rescue for everything. And are we trying to really make the patient feel better, or are we just trying to make them shut up? And that's unfortunately reality. Anesthesia is not a cookbook. You're going to see the further you get into it that there's more and more variables that come into play. And what we want you guys to have is kind of a reference point for things, but then you start taking into account all these other factors that influence what you're going to do. So this was an interesting study. They looked at some barriers to implementing ERIS, and they did kind of interviews with a lot of the stakeholders. So it's interesting the perspective of people. The surgeons are going to put the blame on us because preoperative fasting is obviously a barrier. As I said, in spite of pretty clear guidelines, we keep saying, NP after midnight, they've got to be NPO for 8 hours, even if they really don't. So the surgeon's probably right in this approach, even if he's still trying to blame us. Anesthesiologist was pretty honest. It's a change from his routine, so you're going to have compliance issues. He didn't say, no, I'm not going to do it, but he basically said, no, I'm not going to do it. And there's a lot of trouble holding people accountable for things in healthcare. And then from the nursing perspective, anytime you change things, people are skeptical of it. It takes a while, and usually like a clearly demonstrated case of something working pretty well before people realize it may be beneficial for them. So big outcomes from ERIS, we reduced our morphine equivalent use. We have improved pain scores, which seems kind of counterintuitive. Especially if we're dependent on opioids for pain management, it seems strange that patients get better when we reduce their opioid usage. And then finally, decreased length of stay in the hospital. So one of the problems you run into with a lot of these different ERIS techniques, especially as you start adding in more medications that may be more expensive, is that there's more upfront cost or there's more anesthesia specific cost. And sometimes it's hard, especially for facilities, to see that little bit of upfront increase, say if you're using a medication like dexmedetomidine or like Exparel, which is long-acting regional anesthesia medication, it's beneficial for the patient because they get out of the hospital and they're comfortable, so they stay out of the hospital. So you may have to justify your use and kind of practice for some of those things. All right, I'll see if these links open up okay. As I said earlier, one of the issues we've really had is being our own advocates and kind of leading the way. The ERIS pathway and opioid-free anesthesia is really one of the things that CRNAs have taken advantage of and run with. We've done a really good job of getting out there and, like I said, truly leading the way on that. If you haven't looked at it before, there's a Society of Opioid-Free Anesthesia out there. They have a conference every year that's really good. But this just kind of talks about how CRNAs are reducing opioid use, improving outcomes, and lowering costs for patients. And as I said, this is really one of those things we drive. And it's interesting because while there's a very low number of CRNAs that have prescriptive authority, we still are a pretty significant user of opioids, meaning that we administer a large number of opioids to our patients. So that was something big for us to change. And this is really just taking you through what I've talked about before. This is available for you open source on the ANA website. And one of the other things we're going to look at is also from the ANA website. So ANA has a whole section on enhanced recovery after surgery. And there's a guidebook in there. You guys, as student members, should be able to download a copy of this Enhanced Recovery for Major Abdominopelvic Surgery. It's an electronic book that's available to you. There's position statements, specific protocols from different institutions, spine surgery, something from UC Irvine. There's some webinars if you want some additional training on it. But I'm just going to take you through a couple of the different kind of perspectives here. And a lot of this we talked about already, but up front, patients receiving some sort of preoperative counseling. Originally, this was done in person. Now we're doing a lot more of it either over the phone or through some sort of virtual presentation. It may even just be as simple as a recording or a movie that you want them to watch. Talk about things that they're going to need to do, things that may be different from surgery in the past. Hey, I really want you to drink this Gatorade the morning of the surgery. Consider if you have somebody that's high risk for PONV, writing them a prescription for Emend or a scopolamine patch so they can have that ahead of time. We're really bad about putting scopolamine patches on patients too late. They need it at least 6 hours beforehand. An hour before is not going to cut it. Make sure that they're getting all their prescriptions filled. Sometimes we're starting patients on a PO antibiotic the night before, especially if you have somebody with cardiac issues or valves. We may consider starting them on something PO ahead of time. Making sure everybody's on the same page. One of the things we're really bad about is having patients come in for multiple surgeries and we don't talk to each other. So they'll have one surgery today and then maybe even one scheduled in the afternoon. So they go multiple anesthetics. If we can get everybody on board, it really works out well for us. Other things, talking about the use of incentive spirometers, deep breathing exercises, getting them to change things ahead of time. So like I said, quitting smoking the day before is not real beneficial, but if you can do it like 4 weeks out, that helps. Same thing with avoiding the use of alcohol, like 4 weeks out. If you have patients that you've identified as being anemic, what can you do to correct that ahead of time? Chronic pain patients may consider some sort of onboard meeting between their pain management specialist and the anesthesia team. And then the other part is to reduce infection risk. Sometimes we'll have these patients either wipe or shower the night before with some sort of chlorhexidine-based product. So preoperative, we talked about morning of the surgery. We're going to go through basic guidelines. Again, we're trying to maintain normal glycemia, so bringing them down to a reasonable limit. Don't give a whole lot of IV fluids. So for a long time, we would hook patients up to fluids in pre-op, and you'd walk in to pick up your patient, and they would have like a liter in already. And it was essentially wasted fluid if they didn't really need to be resuscitated. As I mentioned, we've moved away from normal saline, primarily using Plasmolite or LR. From a multimodal standpoint, a lot of times they're getting Tylenol, gabapentin, and Celebrex up front. Some patients, depending on the specific case, may require something else. Think about like Enterig. Some sort of standardized PONV assessment. We mentioned APFL being one of the more common ones. So intraoperatively, and this is one of the things I really want you guys to pay attention to because it's got like specific medication regimens and when you should use it. We talked about using short-acting anesthetics, so we're able to get that patient back to baseline quickly. Minimizing opioids. One of the things here is consider beta blockers for laryngoscopy. We know that cold laryngoscope being inserted is going to cause a sympathetic surge. So what we do a lot of times to compensate for that is we'll actually administer a small dose of Esmolol in place of fentanyl prior to laryngoscopy. They're going to get a bolus of lidocaine, usually a higher dose than kind of what you learned in SimLab, so like 1.5 mg per kg. And then we're going to start them on an infusion. Usually what I'll do is like 2 milligrams per kilogram per hour. And then, like I said, I'll give them a bolus of ketamine with a subsequent follow-up. Magnesium has come into play because it's a nice muscle relaxant and it helps out a lot with pain pathways. Usually what I'll do is 2 to 4 grams prior to incision. Some places will go ahead and do a continuous infusion throughout. The nice thing about this stuff is it works well. The downside of it is it can be kind of labor intensive. So when you get out in your clinical practice, you're going to have to stop and figure out kind of what you can do to get around meeting your patient's needs versus the workload that's associated with it. So if you stop and look here, you've got a pump for your lidocaine, a pump for your ketamine, a pump for your magnesium, a pump for your Precedex, and a pump for your propofol. Very rarely are you going to have that many pumps in a hospital OR. So you kind of have to pick what you need to have on a pump versus what you can use as a push. Yeah, in a perfect world, everything would go on a pump, but it's not realistic. So as you head towards the back end of the case, consider Toradol if you haven't administered it. I usually administer my Decadron up front, but you can also consider a second dose of it. If they have not already received PO Tylenol within a specific interval, you can consider a second dose of that. And you can also consider performing either a neuraxial or regional technique. One of the other things you're seeing that's changing is we're going and doing these, we call them post-induction. So a lot of these neuraxial or regional techniques will either be done after the patient has gone to sleep, but before the surgery starts, or maybe even in day surgery. So if it's something that's not real uncomfortable, I may go out and do the regional block ahead of time. And this last one just kind of shows you a combination of things. So just because you have a regional block done doesn't mean that you're not going to use general anesthesia as well. And you can do a wide variety of blocks as well as putting in catheters versus single shot. Just kind of reviewing what we talked about, using kind of purposeful goal is for your fluid administration, avoiding normal saline. For neuromuscular blockade, you want to try and make sure you're using a quantitative monitor. Some of our operating room monitors have a monitoring system built into it, so you actually get a specific value as far as your degree of reversal. Making sure that you're adequately reversing patients that have received neuromuscular blockade. Again, continuing on with kind of normal things. If you've inserted a gastric tube and there's not a reason to keep it, go ahead and take it out. Same thing with Foley's. Try and limit the portals for infection. So less catheters, drains, lines, really just limited to what you need. Post-operatively, avoid fluid overloading the patients. Again, continue the goal-directed therapy if possible. There's some debate about what fluid to use afterwards. You'll see some places go to D5.5 NS. Some places continue with like Plasma-Lyte or LR. And try and transition those patients to PO intake as soon as possible. We know that the IV fluids, no matter how perfect we think they are going to create a little bit of an inflammatory response. So if you can get back on that normal pathway with PO intake, great. You may need to continue PO/NV treatment in those patients. You'll see a lot of times patients do really well until they do start PO intake. So continue medications at least up to that point. Usually they're going to go through a progression of diet as usually start off with clear liquids and then they'll move on to something a little bit more solid or gelatinous, jello pudding before they finally move on to regular stuff. Consider post-operatively actually having a schedule of medications for the patients. One of the big things we try and avoid is medications that are a combination of Tylenol because you may actually overdose your patient on Tylenol. So we'll give Tylenol by itself, Toradol and ibuprofen. You may consider continue with the COX inhibitors, gabapentins, muscle relaxants, tramadol. And you can still use opioids. We're not saying don't, but just consider stuff ahead of it. And again, consider PO stuff because it's going to maintain that steady state for that patient a little bit longer. Other things you can continue post-operatively, either infusions or doses of ketamine. Some places are continuing lidocaine all the way up to the floor. I personally have some kind of concerns about patients going to the floor on cardiac medications or cardioactive medications. I don't have a problem continuing to PACU, but going up to the floor, I'm not sure about. Other things you can consider, like we talked about PCAs, decreasing the fasting period, and then to get the gut back to kind of its baseline status, decrease the fasting period. You can use Interreg, something that stimulates it like PO intake, or even just as simple as chewing gum. The ability to limit opioid administration, getting your NG tubes out, and then moving forward with your goal-directed therapy. And those are really the big things I want you guys to think about with this. So if you have any questions, that's definitely available for you to go back and look at. The ANA has some great resources available there. And that's all I have. What questions do you guys have?